Okay, so today we are going to discuss what we saw today at the rounds and what did we see. Okay, I was seeing a patient. His name was, let's say, Ghulam Nabi, and he was a 56 years old person. And he presented with chest pain and dizziness syncope. So when I examined his chest, I was able to listen to a systolic murmur, and that systolic murmur was loudest at the mitral area and was also heard at the aortic area, and it was not radiating to the carotids. I couldn't really establish the uh, I couldn't really establish the breathing, its pattern with breathing, because the patient was not really that cooperative. So for me, my top differentials were it's either a mitral regurgitation or aortic stenosis, and his echo came out and it said that it was in fact aortic stenosis and its radiation was in the mitral area. So yeah, this was the finding of today. Then there was another patient who was a known case of ischemic cardiomyopathy, and he was only 29 years old, and just 5 months ago he had like anterior wall MI, and his angiography was done, and it was found out that his LAD, left anterior descending artery, it was blocked, and they placed stent in him. So this is very very not usual and very bothersome, the why we are getting such young myocardial infarctions. Then on the next bed, I had a rheumatic heart disease patient, who had aortic stenosis. I could only appreciate her loud S1, and she had aortic stenosis as well as atrial fibrillation. And for rapid ventricular rate, she was admitted multiple times in the hospital, and she was advised to undergo a surgery. And she was not really going for the surgery, because once when her surgery was appointed, she really felt like her her left leg was not moving. Her arterial venous Dopplers and everything was done, and it came out that it was in fact a functional neurological thing. It was a conversion disorder. So yeah. Okay, if I talk about the next bed, it was non-ST elevated MI and ACS, hypertensive emergency, and NDS. And the next bed was the patient had today he had the fifth day of admission, and on his fifth day of admission he had he was a known case of ischemic cardiomyopathy with ejection fraction of 20 to 25%, and he has multiple hospital admissions with pulmonary edema. Now he was doing good, he was sitting upright, but he had very much of the he had pedal edema, too much pedal edema, that it was oozing out of his skin, and from where it was oozing out, it had actually made it to cellulitis. So we started him on antibiotics, and his creatinine initially was 1.9, and we will repeat it. We have sent a repeat thing. Another important thing is that although he had congestive hepatomegaly, and his bilirubin was raised at 7. Usually bilirubin is 0.9 or 0.1 or very less, but his bilirubin reached to a 7. An isolated bilirubin rise, I checked its hemoglobin, it was at 10, and MC was on the lower side around around, I guess, 60, 69 to 65, and his RBC mass was also good. So we can say that there were very less chances of hemolysis, but his bilirubin was raised. So I looked it up and I found that it can happen in congestive hepatomegaly for bilirubin to rise to this level. He also had jaundiced sclera, and that had been there for the last 3 months. He had renal edema from last 4 months, and he had jaundice from last 3 months. So yes, these were the cases that I saw today in the cardiology department.